All right, I think we'll get started. Not only will this be available now, but it'll be recorded and then we'll put it out on YouTube and people can watch it. But today we have Robert Grabowski from Metro Life Flight and now kind of helping start another program out in Nebraska. He's going to talk. This is the third of four discussions with talking about the nurse practitioner role in critical care transport. And I know some people on here have been on the other lectures, but for those who haven't, the reason I'm doing these series of lectures with different nurse practitioners from different programs who use nurse practitioners in their critical care delivery model is really to raise awareness and gain different perspectives from these NPs about the NP role in CCT, and then also how to implement that role, to discuss the values of NPs in critical care transport, to share best practices for their use. And today we have Dr. Craig Bates, who was instrumental in developing and starting the nurse practitioner model for Metro Life Flight. So we'll get his input on that as well. And probably the biggest goal for me personally is to increase awareness, hopefully, and just get this information out there for other programs who may be on the verge of toying with using nurse practitioners in their model. Because what I'm seeing is a lot of flight nurses, they're at the pinnacle of their career. They decide to become nurse practitioners, and now there's not many opportunities out there for them, except for in a select few areas. So a win for me in 20 years would be to have 100 programs or so flying with nurse practitioners. Whether that'll happen or not, I don't know, but that would be a win for me. So this paper is now public. Robert Grabowski played a key role in helping publish this paper that discusses the role of nurse practitioners in critical care transport. I'm sure some of the things we'll talk about today will also be discussed in this article. And Robert, I thank you a lot for all the editing and reviewing. I think you're a better publisher than I would be, and because you're the way you put words and stuff was really awesome. So thank you. And I think with that, I'll hand this over to you, Robert. Tell about yourself, tell about the program, not only Metro, but ProMedica, and then now what you're working on in Nebraska. And then we'll see where this goes. Like I said before we came online, there's a certain number of questions that Tanner and I want to get to. So whether you cover them here or later, we'll just see where this goes. So I'll hand this over to you. And then Dr. Bates, you can introduce yourself as well. You're muted, by the way. There you go.
Yeah, I got you. Thanks. I'm Robert Grabowski. I'm the Chief Flight Nurse Practitioner for Metro Life Flight here in Cleveland, Ohio. I've been in this role for about the last 6 years, been with the program for coming on 12 years now. Moved out here from Michigan, originally did some fixed wing work out there, and did my nursing career in the Toledo area before coming to Cleveland to attend Case Western. So I'm an alumni of the flight program there that Dave is running. I came out to Case and did my adult acute care NP, my flight ACNP, and then went back and did my pediatric acute care NP as well. And I've been flying with Metro ever since, full time. So I've kind of been a big advocate of the NP model. I've lectured on it at AMTC in the past and CCTMC. The paper was nice to get out there and publish on, and every now and again I get a few bites from people around the country will email and ask that they're interested in implementing the NP model in their program. So I've kind of helped some people work through some challenges at their hospitals and how to poise it to upper administration and how to really help hospital administrators see the value. So if anybody has any questions on that, we would be happy to kind of roll into that a little bit later. But to tell you a little bit about our program, Metro Life Flight's been around for 41 years. We're a uh, air and I'm sorry, rotor wing and ground program. We haven't done fixed wings in several years, but once upon a time. Um, and we are a dual pilot IFR in a EC-145 model. And then we just recently acquired operational control of ProMedica Air out of Toledo, which we just upgraded them to EC-145 E-lights as well. Also dual pilot IFR model. They're currently staffed as a nurse medic model, but our intent is to help them transition through attrition to the NP model. So that will be some really good growth for the NP model in Ohio, and we're happy to see that. And then my other role right now is as a locum critical care transport NP for Nebraska Children's out in Omaha. They just recently started the NP model about 18 months ago, and they're having some startup pains, which is quite typical. Um, so I'm kind of helping them guide through some of that process and help them with some of their staffing culture, some of their organizational challenges as well, administrative burden, and help with some billing questions and just overall operations of the model. But they're actually doing a pretty unique model out there because it is a children's hospital, and so I'm sure anybody who's been in the industry for a while has seen neonatal NPs kind of ad hoc join on to a transport team, kind of in a safety officer fashion. But they're doing a dedicated neo team, which has a full-time transport NNP and nurse. And then they have a PEDS neo team, which is staffed by a pediatric acute care NP, also full-time to transport, and a nurse as well. So it's the first that I'm aware of a pediatric acute care NP model. I've definitely seen the NNP model and then the adult side over here. So I was excited to go help them with that. But those are kind of the programs where we're at, and we can jump into some of your questions if you want. Actually, I'll introduce Craig Bates.
Yeah,
He's
yeah.
been our medical director here for the last 15 years. Just recently got promoted to EMS division director over everything EMS here at Metro Health, and I'll let him talk about himself.
Yeah, so I'm in still do emergency medicine about half time. I do administrative and clinical kind of pre-hospital stuff the other half of the time, which can include life flight or supporting some of our TIMS operations, some of the other ground EMS operations that we work with. I was an engineer and was an EMT in college and thought that was way cooler. And so that's kind of how I ended up where I am in emergency medicine. So I was at the birth of our NP program here at Metro Health, like around 2010. And so I can speak some to like the challenges and opportunities it has. But I think one thing is we're reminded of this as we're now birthing kind of an advanced crew member model at ProMedica. So it would be not just NPs, primarily NPs, but also some physicians as well. And then we want to get their residents flying in like a real experience, not like a glorified rider experience, which is kind of what they have now. And to be honest, with few exceptions, like our program, I think Mercy Health, University of Cincinnati, I don't know what Wisconsin's doing. And a lot of the programs have gone away from having the residents fly as actual crew members and more to just being kind of like a rider for a variety of reasons. But there's a lot, people in the industry are very rigid, right? So they have this view of what the care is that's provided, and they don't think outside the box that well, which is surprising considering you think of clinicians and transport as being think outside the box people. But I would encourage you when you're exploring these questions with your home program, like, we found, like, for instance, we had a town hall meeting with the ProMedica crew members, and they have good crew, they have good teams, they have good nurses and medics. A lot of them were just kind of stuck on, they're like, well, so like they can do different more procedures. And it's like, well, yeah, they can do more procedures potentially. It depends on state scope. But they also bring, obviously, the cognitive part is what matters most. I mean, you think of your sick air medical transport patients or ground critical care patients. You do procedures, but not that often in the grand scheme of things. But it's the cognition, it's the decision making. So people are very stuck in a task focused way of looking at things. which is more kind of classic EMS and even some of flight nursing sometimes. But better programs, better clinicians, whether they're a better program or not, know that it's about way more than that, because it's about decision making and cognition. And so I think it's important to try to make sure you're clarifying that it's not just like the ability to bill more, which is nice, or the ability to do a chest tube because in XYZ state, nurses can't do it. But I think it's important to emphasize the values to the patient. And I think actually Rob, when we had a town hall meeting, he did a great job, because the other point he had is when you come from, and the word provider doesn't bother me, but a lot of my colleagues like freak out. So I try to say enhanced scope crew member or something like that. But like Rob talked really well that most people that have either, NPs or physicians have a lot more understanding of the continuum of care as it happens in the hospital, between pre-hospital ED to hospital. And that has value, because a lot of what we're trying to do is bring the hospital out into the field when appropriate. It's not always appropriate, when appropriate. And if you are a person that understands that continuum and has a sense for what the ICU doctor, what she's going to want to do with this patient with ARDS, like in the first hour or two, because you've been there, like you can do things that matter to the patient. And I think that a lot of traditional, even strong EMS programs are not necessarily going to see things that way. So that's a way kind of to try to break people out of the rigid view of things.
Yeah. Well, much to get into. I do want to say that we have a chat going for questions. If you can type them in there, we'll ask them. Either we'll have the question coming up, so we won't ask it immediately, or we'll make sure it gets asked at the end. And I think with that, we'll roll into questions that we came up with. So I think you already did this. You described your experience with CCT. Robert, have you worked for any other critical care transport programs besides Metro, either, let's say, EMS or critical care transport in general?
Sure. So I started in fire and EMS, worked for a primary 911 ALS system in Michigan, and then went to nursing school. It was actually Survival Flight of Michigan, that University of Michigan program that kind of started me down this path. I did a scene run with them, and their crew configuration at the time was nurse. And for the 515, I was getting paid an hour as an EMT basic, and I was like, I should probably find something that pays better, and this flight nursing thing seems pretty cool. So that led me down that path, and I started doing ER and CV surgical ICU, and kind of building my resume to go to a flight program. My first CCT experience was a fixed wing program out of Michigan. I did that PRN and then did it full time for about a year and a half. And that was domestic and international CCT, fixed wing, like I said. We had a big Department of Defense contract, so I got do a lot of military transports, and then also just some out of the country, medical disaster kind of stuff, or U.S. citizens that have some problems and need to get repatriated or go to a different country that got injured here. So that was kind of my ease into the CCT world through fixed wing, and then like I said, I've been at Metro for about the last 11 so years. I did get to experience some clinical rotations at Cleveland Clinic's program when I was at Case finishing my flight NP, so I got to fly with them and Dave Holloway, who was here last time. And then now with Nebraska Children's as well. But yeah, that's it for me.
Great. I don't know what
Real
happened.
fast, Rich, we'll get to your question here in a couple slides. Thanks for asking.
Hey, Tanner, can you just handle the chat? Because something happened when I went to look into the chat that I didn't see anything for a while. All right.
Yeah, I got it.
So you've been involved in CCT since when? 2000?
I started fixed wing in 2011, I think.
Got it.
So that would have been my first CCT job.
I know this, but this will be we can get into this now. So is your specialty family or acute care?
So I'm dual boarded in adult general acute care and also pediatric acute care. I do not have a family or ENP certification. In Ohio, as a general rule, the trend for inpatient healthcare services has been towards the acute care NP model, particularly for critical care and emergency medicine. There are definitely still large swaths of EM practice that are being done in Ohio by family NPs. It vastly depends on your region and the hospital system. Just as a bit of perspective, in Ohio, there was a board of nursing issue probably about 5 years ago now that the board had put out this, I wouldn't even call it guidance, but a generic statement in one of their regional magazines, and essentially said that FNP should not be providing acute care services, which ignited a huge debate amongst the nurse practitioner crowd in Ohio and hospitals in general. And they held some hearings and put together a subcommittee, and in the end, they had the Ohio Attorney General make a statement on how the law is read and interpreted, and in the end, they didn't come up with anything. Essentially, they're still saying a nurse practitioner is a nurse practitioner, and it's heavily dependent on the amount of training that your home facility and collaborator put into you and what they determined you to be trained and found competent to do. At LifeFlight, we do not fly NPs, or I'm sorry, family NPs, just for the sheer fact that your baseline education, the requirements for you to get into school are vastly different than what we're going to be demanding of you as a clinician in the CCT environment. If you are an ICU nurse and you got an FNP degree and we provided you a bunch of extra training, could you do the job? Probably. There are definitely these cases that people say, I've been in a emergency medicine FNP, or I've been an ICU NP for 35 years, and I'm sure there are one-off cases, but to me, the concept of credentialing as a provider has to be able to be generalizable to an entire population. And you can't, in my eyes, you can't do that with FNP. You can find people with an FNP degree that can likely fulfill the scope and role for the demands of the job. But if you're trying to kind of identify by the lowest common denominator what you're going to guaranteed get from a clinician based on their certification for the role of CCT, in my eyes, it has to be acute care.
Yeah. How
Plus,
about
plus the risk of some random bureaucrat like sweeping a pen and suddenly saying, if we had FNPs, oh, they can't do this or whatever. I mean, we talked during prep, like the way, and it's none of your guys' fault, but the way that the specialties and such are done for nurse practitioners is just a giant dumpster fire, right? Like, I mean, it's a lot of vagueness in different states. Like in Ohio, I don't even think I can find it on Google anymore, but someone in Ohio said that ACMPs, adult ones, shouldn't care for patients less than 14. And so like, we couldn't get a straight answer from regulatory agencies. So like internally, like the way our credentialing reads, it doesn't, Rob is dual boarded, so it doesn't matter, but most of our people are adult ACMPs, and the way it reads in their credentialing paperwork with the med staff office is that if it's a patient less than 14, they magically turn into flight nurses, basically, like legally. And so they still do like the same stuff. It's just they may have to interact with medical control more frequently, but we haven't changed like the procedural scope. It's just sort of a thing, just a nod to that vagueness to make sure that everybody's happy.
Yeah, the reason I asked this is because I was I think, like you put it, Robert, there are certainly FNPs who can read the same content on their own and learn things and work with ventilators and do the job. But at the same time, I'm asked by people who are choosing, do I want to go FNP or do I want to go ACNP? And I want to give them an honest opinion. So I generally tell them that they should become either both or only acute care nurse practitioner. And that's in the state of Ohio. And that's what the scope of the transport programs that I'm familiar with. the Cleveland Clinic and Metro Life Flight. Now, it was interesting because for Vanderbilt, and I don't know what the scope is in Tennessee, they were completely fine taking FNPs who work at the emergency department. Now, I'm certain those FNPs are probably wicked smart. They've worked with ventilators, but I also want to give people thinking, which way should I go? I want to live in Ohio, and I'm here an acute care nurse practitioner.
Yeah, I would agree with that. And I mean the state scope problem is going to be vastly different. If you read the Ohio revised code for some of this, it is so ambiguous that essentially it would say, hey, you're an adult Gero ACMP. You spent 2 years in school learning critical care management for adult patients. And then say I went to CASE's flight program and I took a 1 semester PEDS critical care transport course by Ohio revised code in the most liberal interpretation, that would say, yeah, I've been trained now and I can now take care of this entire different specialty population because I've received some form of training on it. Because it's very ambiguous as to what training entails and to what degree, and is it grad training? Is it on the job training? And I think that's really a disservice to put ourselves in that position to say, yeah, I've been formally trained in this one specialty, whether it's, adult acute care, and I took a 1 semester class on peds, and now I'm a, a pediatric intensivist for all intents and purposes, or that, for 2 years I did clinicals in a family practice office or in urgent care, and now I'm going to be titrating vasopressors and ventilator management for an ARDS patient because I received some form of onboarding training. And again, I hesitate to like really delve into this a whole lot because it does sound like you're just FNP bashing, which I'm not. I think like I said, there are great FNPs out there, and there are certainly FNPs that are probably operating within CCT and are doing an amazing job and probably can teach me a million things on critical care management. But what I try to bring it back to is, what am I going to be guaranteed to get from this level of practitioner? One of the things I'm working on the side is I'm an Army reservist, and I'm working with some leadership in the nurse corps to try to get acute care NPs recognized within the Army health system, as they traditionally have not been. And they're really trying to push FNPs, generalist PAs, and now they're investigating the ENP, the emergency NP model, to kind of cover these gaps in intensive care. But to me, like, yes, there are certainly people, but if you're talking, especially an institution as large as the Army or military health system or the Defense Health Agency, I need to be guaranteed, because I can't look at every single individual and say, well, yeah, this person had ICU experience as a nurse, or they meet this random criteria. I need to know for sure that the minimum expected abilities of this person are going to be met across the board because they've been credentialed and verified by an outside agency. And that's the whole point of certification, right? We get certification to guarantee a minimum set standard. And then if we accept a different certification, it kind of negates that whole concept.
Right. Or a lack of certification. I mean, this always gets sensitive, but you guys are more at the forefront of like what happened in emergency medicine 10, 15, 20, 25 years ago, right? I can certainly think of a family practice doc who's worked in some place in Alaska and has seen some crazy crap in her career, right? And is really good. But at some point you have to kind of draw the line, and there is some value to not just the experience, training plus experience in the right way, with supervised mentorship, with people that know what they're doing, people like Dave Kanicki or Robert here, and there is value in that. And I think, in my knowledge, it's actually kind of funny that some people act like putting NPs in the aircraft is somehow something crazy. I would actually argue that it is a better use of nurse practitioners in a critical care transport team than probably in the ED in some ways, just looking at the skill set and experience, because critical care transport, it has a nice focused thing that like you can get really good at even with less experience if you focus and work hard and have good training and good like supervised practice. whereas with our emergency medicine NPs, like they're really good. We have some that are great, but sometimes they don't have the biggest database of cases as big as someone that's been doing a lot longer or had longer training. But with our NPs on transport, like I don't even know if I can think of a time, except for something really strange that wasn't really a common transport thing, that one of our NPs was calling me and didn't really know something about something, right? They may have been like, hey, I want to get your perspective. Have you seen, what have you think? But it's not like they were just out of their element. And so it is kind of a natural use for a properly trained NP. And I'd argue that the most consistent, reliable, and reproducible way to train someone for this practice environment is make him an ACNP. You want to future-proof yourself, make yourself adult and peds, and you can take care of all ages. But I think that should be the future. Now, I don't know what's going to actually happen, but that's what seems to be the right answer to me.
And
Yeah,
Can we
I
just
agree.
do a question real fast?
yeah,
So, Dr. Bates and Rob, we're going to get to the pediatric stuff in a second, but I just want you to start thinking about this question. Rich asks, is there an emphasis on having more advanced practice providers who can care for pediatric patients? But we'll get to some ped stuff later, just if you can start thinking about that. If we can backtrack just a little bit, and maybe Dr. Bates, you can talk about how this came to be. Can you describe your staffing model? Jeremy asked, and I think that is about LifeLight. Do you have an APP on every aircraft or a specialized team with flight requests triage to that team?
We have just about every model possible if you look between ground and air. So, on our ground side, it could be 2 nurses and a driver, it could be nurse, critical care paramedic, and a driver. On air, very rarely nurse, but I think 97 or 98% of the time, maybe a little higher, it's either going to be an ACMP plus a nurse, or it'll be a physician plus a nurse. And the physician could be a senior resident, it could be a moonlighting emergency physician, or an attending EM doc at our own facility. Because of our model, we're quasi-municipal, we have a lot of flexibility in staffing. And this is one thing we pointed out to the folks at ProMedica when we did the intro meeting, is that we could have physicians, because they have some very experienced flight medics. And I would argue that some of their most talented crew are their medics there. And so we're like, you can have physician medic, you can have NP medic, right? We can have any mixture of different things, and there's pros and cons of different models. And so I think being willing to have flexibility is important. And as far as it's funny, we have requesters that care a lot about our crew configuration, and we have requesters that don't care at all. There seems to be very little middle ground. I think people have a general sense that they think we're really good at what we do. And it seems that a lot of times that feeds into even our non-advanced practice, provider or physician staff crews. But I think also, like, our nurses work in all the models. They work air and ground, they work all different crew members. And, when you work with other people, if you work with someone that is at your level of skill or experience or greater, right, you're going to learn, you're going to push yourself, you're going to drive, there's positive internal competition to do better, to one up or whatever. That's a good thing. And you're less likely to coast. And I think that our nurses are a lot better because of it. They get also advantage of additional education experiences because we're feeding a residency program, a fellowship program, and we're keeping our acute care NPs at the top of their game. And so the nurses are bearing the fruits of all of that. Plus the fact that they have the NPs, it's like having a bunch of like CNSs, right, circulating through the team, educating like ad hoc one-on-one or during a trip or in small lectures, big lecture sim. So there's a lot of benefits it brings. And so that's why I'm biased, obviously, but I think our nurses are better than the average critical care transport nurse for a lot of those reasons.
I would concur. Robert, if there's anything you want to add. Otherwise, I do have one other question. I don't know if we're really going to get into this, but Robert, maybe you can provide like 2 minutes on it because we do have a lot to cover still. Nicole asks, generally, do you apply for a position like flight nursing for the Army as a new nurse and get trained by them? Or do you go to a grad program first, then apply to the Army or Metro, et cetera, after? So I think, Nicole, if you're talking about how to get into flight nursing in general, Robert, maybe you can talk about that for a second. I don't know if we have time to cover kind of the Army, and it's so specific. But if you want to delve into that really quick.
yeah. So And if you listen to Keith's lecture the first time around, I think maybe that's what she's hinting on, because Keith mentioned at Vanderbilt, all the NPs had to start as nurses. So for the NPs here, you do not have to start as a nurse. Incidentally, all of our NPs were flight nurses prior to becoming NPs. And or no, I
No,
forget.
actually, our last couple.
Oh, that's
hires,
right. Yeah,
it's actually-
our newest hires broke that trend. For the longest time, everyone was grown from within the team. But we did recently hire, not recently, it's been a year
Yeah,
plus.
Rob deployed and everything went to hell and I just
Yeah.
hired random people.
Everybody changed everything behind me. So yeah, we do have NPs that were not in critical care transport prior to coming here. One of them did complete the case course, the other did not. She was in a busy house officer gig within the Cleveland Clinic system and had a lot of good, diverse, autonomous experience. But no, so you don't have to apply at either program that I'm at to be a nurse prior to being an NP. You would just apply for that role. Uh, and
Yeah, that transitions to the next question. Like, what are you guys looking for when you hire a nurse practitioner? What's the ideal candidate? Both. We kind of talked about FNP versus ACNP, but what are you looking for? Are you going to hire a new grad? Or are you going to hire? You want experience in the ICU, experience in the ER? What does Metro Lifeline want?
so generally speaking, we have shied away from new grads. And I know, speaking to other colleagues in my role at other institutions, that the new grad generally does not have an easy road to success within critical care transport if they make it through orientation. It has been our experience that a key determiner of success is either going to be a pretty vast amount of experience in the transport realm already from a nursing experience. If they don't have that, generally a form of critical care management experience in a highly autonomous role. To me, that doesn't mean it has to be at the level 1 trauma center, tertiary academic center. And honestly, a lot of times I feel that tends to be a disservice to some NPs, because you have so many residents and so many other varying levels of providers. They don't necessarily get that autonomous decision making that would be helpful in critical care transport. If you have a level 3 or something that gets a good mixture of medical, surgical, critical care, and the APP is the primary decision maker day to day within patient management of, say, an ICU, I think that level of experience tends to help them along more than the tertiary center, because there's no attending for you to necessarily just turn around, walk down the hall, and ask for help. Granted, you will always have medical control physicians that you can call back to for guidance. But my experience has been the people that do the best in this realm have a very autonomous role in previous roles prior to coming here. I think that has helped people the most.
Yeah.
Would you agree?
Yeah, and I think that psychologically, being in an autonomous role, even if you're making the same decisions you made before you're in an autonomous role, like even like use an example, our first like 2/3 of our first whole chunk of people we hired basically had been flight nurses with us and then went to school. And it was actually really interesting to watch kind of them go through that transition, because these are people that I knew routinely were comfortable making autonomous decisions. But you could tell, like, there's this additional weight now, like, like, I mean, you could still call medical control, but I think that maybe a little more realization of the added responsibility and the added expectations, and heaven forbid something goes to court, that is not an easy thing. And you even see that if you guys work around residents when they're in training, you see residents as they go from like med student to first year resident. And then the next big transition is when you're the senior resident or a chief, and the next big transition is the first year of practice. And I think you see analogous things with nurse practitioners. In something it's not any of your faults, but one of your challenges is there's not as much consistency and the training and experience you guys get as you go through. With in the physician world, like if I graduate EM residency, like people pretty much know how much autonomous practice I've had, how much supervised practice. but kind of Rob alluded to, like you can have a vastly different, when we interviewed people, we interviewed some really good people, but some people were essentially acting in almost like an old school physician extender role, right? You know, they were going out, they were probably having fun, they're doing cool procedures, but that's like all they were doing. They weren't making the decision, you know, about, because that's what matters, is making the decision that this patient needs this procedure and when do they need it and how are we going to do it to make it safer for them, and blah blah blah. You know, they were just sort of like a procedure monkey going out there, and that's not who you want in transport. And this gets back to the question of hiring new grads. I mean, I think if someone is a new grad NP, but they were a flight nurse for a long time before, you know, we're going to take a hard look at them. If someone is a new grad NP but had not worked in flight nursing or a very autonomous role, I don't think they would be likely to succeed in orientation. They would struggle. And I would also add that I think it is so important as a flight nurse alone to have actual critical care, like ICU experience. It doesn't have to be all of your experience, just at least some, not just EM and field, because you see different kinds of patients. For most of the kinds of patients that the transport teams in this region, this state are seeing, you need that experience because you get some pretty sick, complex ICU patients. It's not just trauma scenes, you know, and some of them are sicker than crap, as you guys know. So I think that's really important. I'm rewinding the experience of all of our folks. Like the NPs we've hired have all, if they didn't have flight nursing, they had pretty extensive tertiary care ICU experience when they were a nurse. And the two, Drea and Amanda, had worked in, actually Drea did critical care house officer. Yeah. Amanda worked in the neuro ICU at the Cleveland Clinic, which I've heard see some sick patients. So, you know, I mean, I think they both brought high level decision making, and you know, you guys know how complex these ICU patients are. They have a problem list that's often 8+ things long, and the ability to get used to dealing with that and churning through the list, figuring out which problems matter for the next hour, which problems don't matter, and being able to reprioritize is very hard to learn on the fly when you're trying to learn how to be a flight crew member as well.
Yeah. Tanner, I think we covered what specific training do you recommend to prepare for an NP role, huh?
Yeah, I would agree. And I think that, you know, if I can kind of summarize, you know, you can learn how to the crew resource management and the safety on the aircraft and whatnot, but it's kind of foundational to have that critical care experience in a you know, the more diverse experience, the better. And especially as an NP, the autonomous role is really helpful. Would you guys agree?
Yeah.
You know, when people come through the program, and I'm a straight shooter, you guys know me, I tell them, and it's good to hear other people say this, like a couple classes can't prepare you for the world of critical care transport. It's the flight nurse experience is great, and also the independent thinking and making decisions by yourself. So I generally tell them either go to a regional ICU where they're seeing everything and not a lot of support. And I do think personally the people who have already been flight nurses have a nice track to becoming an NP, because the bridge to both making the decisions and learning the transport environment it's just, I personally would never hire that person if there's other candidates, right? So it's good to hear others. And I feel that everybody is saying the same thing who's hiring in the transport.
Yeah. I
think
don't know if I could weigh one more than the other, but anecdotally, I feel like clinicians have a harder time learning to be logisticians in transport versus the people that have been flight nurses first. I feel like learning the medicine's just a little bit easier. But I'm seeing so the program in Nebraska has been using some locums providers as they're standing up teams. And so a lot of times these are very experienced clinicians, but have never worked in critical care transport. And it's challenging when you take a very experienced hospital provider and then throw them into the transport realm. I think that transport nurse experience really goes a long way to ease that learning curve, because even after months and months, like it's still not an ingrained environment for them.
Yeah.
So I do feel like if you are on that path, I would try to at least get some flight experience, whether it's a medic or nurse, whatever your role is prior to going in. I think it will only help.
Yeah, and I fly regularly. I mean, I was been hurt the last year, so I haven't, but I plan to go back to flying. But my practice of emergency medicine and critical care is different in the aircraft, in the field than it is in the ED. And I have coworkers that I would let take care of my family any day of the week in the ED, but I know they would not excel in the transport environment. And in the predominant US model, the two-person crew, you're not going to be able, it's asking too much of the nurse to drag that experienced locums NP around, right? I mean, maybe if it was a 3-person crew or 4-person crew, you got like a 139 or something crazy, like maybe it wouldn't matter as much. And you just leave them in the aircraft so they don't get hurt. But I think that when you've got a 2-person crew, like you need a lot of contribution from both members. And maybe when it's a simple trauma transfer, one person can drag the rest of the world around, but then you hit the wall when you have a person that's got multiple complex issues going on, machine dependent, like cardiac support patients. That's when you're going to hit the wall, and you need somebody that really can pitch in and do things. So, and the third question on this slide, like, so I'll say this is one of my frustrations and things I'm working on getting here with our program is I really want, and I think Rob does as well, to have some sort of routine experience in other parts of the hospital, like a high level tertiary, one of our ICUs. We've talked about other things they can do, and other programs do this. They might use them also to help out with a comm center triage kind of system role. They can also use them, Cleveland Clinic uses them in a remote kind of ICU decision support role, which is intriguing. But I really want to get them in there because this is a very narrow part of medicine. It's a really cool part of medicine. But if I just flew and didn't work in the ED, I would become smarter in some ways, but dumber in a lot of other ways. And so I guess if you only wanted to do transport the rest of your life, it wouldn't matter. But I think you should keep your options open, and you'll learn new things. You'll hear different perspectives. And so I think that is going to be a best practice moving forward. And I'm doing everything I can to make it happen here. But I would suggest, if you're exploring this at your institution, to try to push for things like that, because not only that, but you build stakeholders that believe in what you guys are doing, right? The more hospitals there's a lot of politics, shocker, right? And the more people you can build that believe in what you're doing, see your team members, whether it's you or your colleagues, out doing great stuff, not just in the field, but in other settings, that can help you out when like the medical exec committee with all the chairs of the hospital or whatever gets together, and they're like, hey, those lifeline MPs, they're really smart. They bring value to the hospital. When can we have people like that in our unit? Can we have more of this? Those are things that will help you win battles. And there are going to be battles when you deploy a program. It's just the reality of hospital politics.
So, Dr. Bates, can you specify you're a fan of putting the NPs in the ICU and the ED, like, maybe a week, a month, or something like that, or are you talking about more the in the communication center, the triage center, or both?
Well, looking at it for the individual clinicians for their benefit, I think it would be nice if we could have some regular ICU experience. And it may just be the logistics of what works best, where they, in some ways, like especially in an ICU, it might be more useful to get more longitudinal stuff to do like a chunk of time, like a week, so you're carrying this, you have patients on your service. The triage stuff, that is more valuable to us as a program. It has some value to the NPs too, but if I was going to prioritize, like I'm asking what's good for the program, it would probably be have them in the comm center, what's best. But what's best for the individual clinicians to feed value to them, which of course helps the program too, would be to find like a meaningful ICU experience. And I don't mean like an ops, I mean like you are a team member, like you are carrying a patient load, maybe lighter at first, but I think that is hugely valuable. And that is one of the things I am definitely seeking out. It's on my to-do list.
Yeah, I want to give my 2 cents here. If I was asked to start a program, that would be one of my top requests is month on, month off. And now wherever, probably the ICU. I'll throw some experience out there. I flew for a long time. I flew for, I don't know, 12 plus years, 8 of that or 3 as an RN and then 8 as an NP. But when I went to the ICU, procedurally, and I know that's not important, but you're putting in lines all the time, you're intubating all the time, and you're just seeing I feel more confident now procedurally, and also I feel like seeing where this is going, the ICU was a huge advantage in doing that. So, there's some bias in that statement, but I think transport NPs can be successful without working in the ICU, but I think both experiences do make for a better transport NP, and that's an
I think
opinion.
I think it comes down to reps, right? So critical care transport, especially rotor, you're gonna have low reps. You just
Yeah,
are. Like it the amount of oversaturation we have and just the volumes and regionalization of medicine, you're gonna have lower reps, 100%. So like you said, I think you can do it without like job sharing in other departments, but that puts a huge burden on the clinician to where are you going to get those reps? And inevitably it comes down to I'm going to have to read all the time. I'm going to have to do sim all the time. I'm going to have to lecture all the time. I'm going to have to like have this huge personal burden to maintain my reps in my head, versus if you can integrate it into the role, then I think you're going to be helping them and set them up for better success. The other challenge is, as just like as a program administrator, is you want your NPs to pick up open shifts and help out with program needs and blah blah blah. If you're not providing those extra reps, a lot of times these NPs are probably going to find PRN jobs in ICUs, other places, so they can maintain their practice and get their reps that they need. And they're not going to be available to help with open shifts and, simming at, whatever comp lab or whatever. So I think it would benefit the program more if you could provide that resource as well. And whether or not it's, like you said, the ICU, I think the ICU would be great if you could like FTE share with another department that has kind of a like-minded goal, or maybe a different ICU that you never transport to, just for diversity of experience. I think there's a lot of avenues you could explore. We've briefly looked into, would a rapid response team engagement look good? Because I mean, that's kind of the model of CCT transport is, rapid response, essentially, resuscitation and immediate intervention and autonomy of care. ICU would be great. Honestly, the dispatch model I think would be still helpful, not as helpful as actual management in the ICU, but that's mental reps, right? If you're the one taking and hearing the calls for every trip that comes through the dispatch center, you're gonna inevitably think, oh, what would I do if I was on that trip? And so that's already going to expose you to, more scenarios in your head to kind of, tabletop sim for yourself. So I think there's a variety of ways to get there, but if you're leading that team, you need to provide those resources. Otherwise, your team's going to find other ways to do it, or they're not, and it's going to become a challenge when you deal with clinical quality later.
yeah.
Very quickly for our listeners, Mr. Holloway agrees with what you guys say. If you guys are interested in seeing how like the clinic does their model, because as Dr. Bates said, they do some triage things. Listen to our previous interview with Dave Holloway, and then Vanderbilt. A lot of their NPs work in the ED and the ICU. That's our first interview. This stuff is available on YouTube. And for the rapid response model, I think Duke Life Flight does that. So you can check out some of those resources and our other interviews for more information about how other programs utilize their NPs.
Hey, so I think we covered education, personal characteristics in somebody wanting to be a transport NP. What are you looking for? Aside from education, what makes somebody successful or unsuccessful in the role?
It's a hard thing to nail down. We have a very diverse group of individuals. I would generically say that personality is a huge component, especially it's a two medical crew, four crew member team. Like you need to be a personable person, be able to work along teams, be decisive, those kinds of things. I wouldn't say that every member of our team is like super aggressive and alpha and taking over the team. And we have such a wide variety of personality types. I would just say generically that confidence in their skill set, but yet a humbleness to know that they don't know everything is huge. Our NPs learn just as much from the nurses as they learn from us. they're like, they have been, especially like our newer NP group, which for the longest time we didn't have any turnover. So we had a very experienced NP group, and now what I've seen as we've kind of expanded the role is the NPs that especially weren't in transport, they're learning a lot about like to be logisticians from the flight nurses. So there's a lot of sharing, and one thing that I've talked to several people that are interested in doing the program or moving to an APRN led model is they're worried about hierarchical changes within their structure. So I think inherently we look for people that are not going to contribute to that problem. So I want you to be confident. I want you to know your medicine and be able to practice autonomously, but you need to be a good team member and not build a hierarchical team. This is, yes, you're an APRN, and the lawyers are going to look at you a little bit more than they're going to look at the flight nurse. But in the end, like, you guys are a team, so you're making team level decisions. So people that contribute to the kind of that shared model, I think are going to be higher on my list. What do you think?
Yeah, I mean, I agree. We have a kind of a laid back program in terms of the sort of the hierarchies, and I think it also reflects an institutional culture that in most of the units here at Metro Health are pretty laid back. I mean, for patient safety and other reasons, our whole ED is basically first name basis. The only time I'm called Dr. Bates is when I'm either in trouble or maybe in front of a patient. So I think that you do need to have that confidence, but tempered with humility. And I think it is, anyone who's been a clinician long enough knows that it's a lot more important to understand your own blind spots and weaknesses and inadequacies than it is to understand your strengths, right? Because you don't hang yourself with your awesomeness. You hang yourself when you weren't awesome. And so I think that people, I mean, there are people in all levels of the medical profession that understand that and understand the importance of knowing their own cognitive biases and weaknesses and things, whether you're a nurse practitioner, physician, paramedic, an MTA, whatever. And there are also people on the flip side that don't. And I think you do not want those people, whatever level they are, how smart they are. You don't want people that have that overconfidence, that are not ability to pause and say, let's have a timeout. Is this really right? And are not able to listen to all of the data available, which could come from a pilot, it could come from a flight nurse, it could come from a med student, it could come from anyone around. And I think we've all seen like the perils of professions that don't do that. I mean, I'll just use an example because I don't think there's any RTs on. I've seen RTs that are like sassing everybody. You can't possibly know what you're doing, that kind of stuff. Like there's no place for that. And it's annoying in the ED, but in a crew of 2 people or 3 people, it could be worse than annoying. It could be harmful to the patient, harmful to safety. So you need to weed out those problem culture things. And I think that our nurses have worried that, oh, the NPs, when they come along, they're going to think they're better or above us or whatever. And like, I mean, obviously, you have committed more to things, right? You've put more money, time, personal investment into something. And that deserves some recognition, but that doesn't mean like you're the colonel and they're like the private. So, I mean, I think we have a pretty flexible structure, but everyone recognizes like if things hit the fan, ultimately in the long run, if Rob is working with a flight nurse, like he's going to have to take more responsibility for what happened. That doesn't mean he's going to command people around. So it is kind of an interesting dynamic, and it's different in different programs. And so that's something you need to ask yourself, how your program is. If you have a pretty strict hierarchy between the nurses and the medics and you're bringing in nurse practitioners, I think you need to sit down and think about, because I don't think that's going to work well. I don't think it's the right way to do medicine, to be brutally honest. I think the higher level you get, the less that crap is tolerable. And so those are things you may want to think about if you're looking at implementation.
All right.
I would add to this list. So
Yeah, I need to write these down.
yeah, University of Cincinnati. I hope they'll be able to get theirs back up. They were some suits and budget cutting swords, knocked them down from the NP team. But I would hope that in the near future they'll be able to get back in the saddle. And there's some really outstanding people that have come through that program, including folks we've hired and folks that I've worked with before.
This is the list of transport teams that I'm aware of in the United States that use nurse practitioners. Can you guys think of any more? Cleveland Clinic critical care transport, Metro Life Flight, Vanderbilt,
It-
Flight 01, Children's
Are
Nebraska.
you looking for full-time?
You know, I'm looking at ones that don't happen to hire them and use them as a flight nurse, but that recognize they're a nurse practitioner. They pay them a little more and they just recognize the fact that they're nurse practitioners. This is kind of what I'm looking for.
We have
Yeah.
that NP model.
Yeah, I definitely am aware of some programs that incidentally use APRNs, not necessarily as full-time crew members. I did recently come across the website of University of Florida, Shands Care, which is a fairly large program in Northern Florida. They market on their website that their crews are either they're nurse medics, like dual boarded nurse medics, and it's either two of them or an APRN and a nurse medic, both on their adult team and their peds neo team. So I'm not familiar with that program. If anybody knows, throw
Yeah,
it in the comments.
if anybody knows, email me dmk104@case.edu. I'm going to put a list of these together and put them on the website and recognize those programs that do. And then I'd like to talk to whoever is and kind of see what they're doing.
Yeah, email Dave and put it in the chat now if you know of anything, please.
All right, Robert. So percentage wise, I'd say you're probably you guys help me with the percentage. I would say most flight, now it depends on the programs, but most flight transport or critical care transport NPs do not have a pediatric certification unless that's the primary role of what you're doing. How important do you guys think it is to Metro? We'll say Metro Life Flight specifically because you kind of have more of a global transport role than just neonatos or pediatrics.
So I would say specifically at Metro, I'm not as concerned about pediatric experience. We can train you to that. And our patient population mix for peds is relatively low. And the vast majority of peds is going to be trauma. So we're not doing at Life Flight, we don't typically do a whole lot of, congenital heart or weird subspecialty medical disasters for kids. It's really your bread and butter peds trauma, DKA, the classic peds medicine stuff that is pretty easily trained. It's going to come down to what your patient population mix and what your mission or your system, your transport model is. Now, if you're doing super heavy peds volumes and you're entertaining or you have a separate peds team, I like this model that I'm seeing of this peds acute care NP leading a peds critical care transport team and an adult ACNP leading an adult team. And then that really solves a lot of your problems. And certainly when you get, close to the 14 to 18-year-old, the adults can certainly handle that. And honestly, all of our ACNPs are keen enough to know how to transport and manage the vast majority of pediatric illnesses that we're going to see here in our region. We suffer from a oversaturation of both critical care transport and tertiary medicine within Northeast Ohio. So there are level 3 and level 4 NICUs everywhere. Everyone has their own team. At one point there were 8 helicopters servicing Cleveland, Ohio. Like we really are oversaturated. So we don't have to be as general as to say, oh well, you're going to see everything based on our patient populations. I don't feel like it's a strong need.
Yeah. I mean, I think it's probably a little hair under 10% of our patients are peds, and the vast majority of the sick kids are bread and butter sick, like trauma, DKA, like things he mentioned, maybe ARDS and stuff. And very rarely we're getting people that are more in the neo range, like, less than 28 days, or you might run into when you get a home birth, like an unvetted person, that could have a congenital thing. Like that is something you not only have to have knowledge, but you need reps, right? Once you step far enough in the neo world, like it is so different in so many ways. You need to be routinely caring for those patients to keep those skills going. So it is interesting. Most, but not all, or I should say many peds teams, and actually definitely most NICU teams are very umbilicated to their home world, right? They show up, they're calling, they're getting orders, and the protocol book for a lot of NICU teams, not all, but a lot of them, is pretty darn short, and is mostly like, yeah, call the NICU, right? Peds teams are far less likely to be that, but dedicated Peds teams, like I would bet it's about 50-50 that are fairly umbilicated back to the home and they're calling. Whereas, in adult teams, it is, I don't know what the percentage is, maybe 5% of the time they're calling. It may be lower than that. It's a very different culture. And so it is interesting that it is a natural thing, assuming you don't like that culture of calling back to your mom or your dad all the time. It is natural, like Rob said, to put an enhanced scope person on that team. But the peds world is very different in a lot of ways. And so I don't know. I mean, but I think that makes sense to me. I think calling back and spending the time to do that is most of the time not a good idea, probably. I think in the NICU world, where you almost never really need to rush, you need to settle, get things sorted, and get going once things are sorted. But in many ways, children, sick kids, especially bread and butter sick like we see, there is no benefit and probably harm to, we call it UDA, unnecessary bad word around. When you spend too much time around at the bedside, there's not much benefit in doing that. You don't need a chest X-ray. You don't need a repeat labs. You don't need those things the vast majority of the time. You can come up with an exception, but the vast majority of the time. So I'm not saying load and go, but I mean, I think you don't need to spend Pete's teams. It's like you need to pitch a tent sometimes, right? 45, 60 plus minutes, NICU teams, an hour, 2 hours, but that's also kind of their standard. And that is not the standard in the world that I function and Rob functions in. So I think that it is very natural to put a pediatric ACNP in that setting. Now, culture is the hardest thing to change, right? And so I think a lot of pediatric team medical directors, they probably become so used to the way they do things, but this is an opportunity for change and an opportunity to expand and have more roles for you guys. I mean, in some ways, you guys are creating a profession, right? I mean, there are people doing it, but this is evolving. This is still, we don't know where this is going to settle out. And so that is some stress, but it's also opportunity, because you can help define what happens and blaze new trails. And hospitals don't innovate a lot. They're very conservative to innovation. Maybe on little levels they will on one service line, but to do a change like this, I mean, even our hospital, I wouldn't say it was a battle. It took a very proactive CNO who was also had a background as an actual clinical ACNP. She, not a mail order DNP or something or anything lame like that, like a legitimate practicing licensed independent provider. She understood, she believed in what we were doing. She supported us. She anticipated landmines. She dealt with the nursing board. She dealt with the medical staff office and helped me. I mean, you need those people to help you to kind of get your program off and running if you don't already have one.
Yeah. So basically, I'll just answer this question. If you're not a pediatric NP, the adult ACNPs, they function as a nurse and they need to be competent, at least at that level, taking care of peds, putting them on a ventilator, not blowing their lungs out, like knowing reasonable ventilation strategies and like that. But I made that transition from all adults, never peds. And, it was scary at first, but like you said, I think it's nothing that can't be learned. And I know a pediatrician, and you might even not like this, Robert. Kids are not little adults, but in many ways they are, I think.
I
think,
definitely
Dr. Bates?
handled like 3 or 4 most of the time. Yeah, I agree.
They're little geriatrics
Yeah, short, fat adults.
Yeah.
The OSA type physiology, right?
with no reserve.
So I guess both you and your ACNPs, so we know that they're at least RNs, but are they all paramedics or EMTs?
No, not at this time. There is some Ohio stuff I'll just say Ohio stuff. Um, that typically would require at least one of the crew members to hold at least an EMT basic certification to operate in and around an ambulance.
Or have two, I think. You have to have two EMP pluses on a transport vehicle. It's a little weasel worded though.
The interpretation though, we've kind of gone away from requiring everyone to have it, as we've interpreted it to be EMT or higher. Other states are going to be completely different. I know Michigan's different. From the looks of it, Florida's different as well. So no, in the Ohio region, we do not require people to be dual certified as a paramedic or EMT.
The nurses
Does-
do though, correct? So
What's
there's
that?
at least one EMT on the vehicle. The nurses are required to have their EMT.
The nurses are required to
yeah.
have an EMT basic, yeah.
Yeah. I mean, with our regulatory setup, I don't think we are held to the minimum, but I'm pretty sure that everyone else would have to have two EMTs pluses, or you have to have a nurse. Like that's in Ohio, at least. OMTB rules let you escape from the head count of EMS board certified characters by having like a nurse, and it can't be a nurse plus. It's actually very specific about a nurse. Now we are exempt from that because we are a municipal operator, like a fire department. We don't have to get OMTB licensed. I have a feeling that that could be challenged. I mean, an NP satisfies it, so it wouldn't matter to you guys. You'd have that person, but I think you could legitimately have a team where you have an NP and a nurse, where neither had a pre-hospital certification, at least in Ohio. That may differ other places. You know, and the role of the EMS board in regulating aeromedical is vastly different in different states. In Ohio, it's literally just the certs. In North Carolina, they enforce protocols, right? And you have to file a deviance. I mean, it is vastly different in different states. Is this experience important? So that's an interesting question. Like, I think I'll give like kind of an example, and I'm not crapping on them, but I think it's a good example. Experience matters, but I don't think it matters when you got it. So like our ProMedica colleagues, they're a nurse paramedic model. Most of their nurses have not done ICU time, and they have very experienced paramedics. They've done very little scenes. And when we've done scene kind of sim things, you know, there've been some bumps in the road, and I'm sure it'll get better. Whereas we have crews that would have had one of the NPs that she had never ever worked in the field. I don't even think she'd worked in an ED before. And she excelled at the scenes because she's done sim, she's done training, she works with people that know that environment. So I think there's no perfect checkbox answer to this. I would never demand that somebody do or not have it either way. It's just part of the whole casserole of experience. I will add that my EMT class as a freshman in college in 1993 remains the most difficult class I ever took, right? I mean, I was new to medicine. I didn't know any of the terminology. I knew nothing. I'd never set foot in an ambulance. That was the hardest class I've ever taken in my life. And it probably had the biggest change in me because the learning curve was very steep for me, right? I knew nothing. Now, obviously, if Rob goes and takes EMT now, what he taken it before, if we took a doctor who'd never taken it before, it's not going to be like that. But there is value to those classes, but you can get that stuff other ways. So I think don't be rigid about it if you can avoid it, but the state may not give you a choice. You may not be able to avoid it.
All right. I think you already described your transport program. Hey, we know how NPs are used clinically, but can you kind of enhance on some of the other clinical responsibilities or ways to use NPs within a program, clinically, non-clinical?
Yeah, so all of our NPs function on a multiple variety of committee structure within the organization. So just like most flight programs, we're in critical care transport programs, we're going to have, you know, safety and quality and education. We have a professional practice committee that kind of helps guide, you know, logistics, supplies, practices, that kind of stuff. The NPs are heavily involved in all the committees. At one point, we did have a designated structure where there was an NP advisor to each committee, not to chair or run the committee per se, but to kind of act as a resource and allow the flight nurses to continue to run and chair the committees, but just act as a kind of a professional guidance if they needed any assistance with any certain aspects of it. Within the quality program, the NPs are pretty well structured in there. So all the NPs manage the chart review portion of the program. So your typical CAMES chart review structures, but also we delve a little deeper in any procedures, any ventilator managements, peds, critical care, those kinds of things. Each NP is assigned an area of subject matter expertise. They're expected to stay up to date on the best literature for their topic. And then those providers read those charts within that bucket and provide feedback to the crew as close to the time of the event as possible. So they're pretty well indoctrinated into clinical quality and quality improvement. We usually try to have at least one QI project a year where the NPs are heavily involved. This year we were lucky that one of our ACNPs is finishing her DNP, so we're rolling that into our airway QI project for the year, and a few of us have done that as well. But there's a wide variety of uses that you can have for the ACNPs outside the clinical role. Heavily involved in the education and training of our staff. They frequently proctor our simulations. They do lectures for the flight staff. They do lectures regionally for EMS and emergency departments. We at one point had a expectation within our group that you either had to publish every year or lecture at least regionally. And a lot of us, like myself, lecture nationally at AMTC or CCTMC, and we hold regional conferences. Ours is actually coming up next week, and we have NPs from our team lecturing there.
Still time to sign up.
Yeah, I forget what
Hospital committees, I think that's
Yeah.
also important for playing the hospital game, so one of them is on the medication safety committee. One has been on, transfusion. So you want to try to get that so to get FaceTime for the program with other hospital departments that you have to work with, like folks like trauma, transfusion medicine, pharmacy. These are really important relationships for a transport team of any kind, to make things go smoothly. And I think probably one of the most important roles is kind of as a small group, as an educator, like more one-on-one mentorship coaching with the flight nurses and with our residents when they come through. It's a natural person to help orient the residents when the residents come through during their time where they're doing a ride, where there is a third when they're still in orientation before they migrate to full crew. The NPs are doing the vast majority of that orientation because they work in, while Dr. DeMarco and I would fly on a regular basis, the NPs fly more. I mean, they're going to fly 3 to 4 times as many shifts as any of us can do because it's their job. And so they get more reps. They are more ensconced in the culture and the experience. And so they're a natural for orienting. And I think, my goal, and we're moving there, is just like in my REM department, the faculty members each have kind of their little niche or thing they do. And Rob's alluded, we've sort of been courting that, but people that can then build a professional niche that maybe that's what they lecture about, they publish on, they teach on, and that increases people's satisfaction. It's proven, at least in the EM world, that reduces burnout, enhances career satisfaction and success. And I would expect that would be the same, even though it hasn't been studied as closely for, critical care transport nurse practitioners.
And I think, well, another example of something that we started to do, but then stopped because of CMS changes, was like the ET3 model for telehealth, medical direction for EMS providers. We have full-time advanced practice providers on 24/7 at these bases. So at one point they were thrown into the pool with EMS physicians to take EMS medical direction calls for directing, destination and that kind of stuff. So I think the next big realm is going to potentially be seeing some of these critical care transport providers being more involved in EMS, not medical direction, but EMS medical direction support services, whether that be quality chart review, safety stuff, lecturing. As we grow as a program and, we have a finite number of EMS trained EM physicians, we continue to grow and add more EMS programs under our belt of medical direction. They need support services. And while your state is likely going to not approve an APRN to be a medical director or associate medical director by terms, There's certainly a number of things that the APRN model can help to add value to those relationships, particularly as that APRN is likely going to be the person they see on a scene request or transport their patients or provide follow-up to them. One of the things we love to do is provide follow-up to our requesters after transporting one of their patients to let them know how they did. And those kinds of things, case reviews of those presented back to the fire departments and such can really be a big business draw, and kind of also help kind of limit physician time burden associated with some of those projects.
Yeah. I mean, a lot of those kind of rules, like terminology matters, of course, and it triggers people. But like, as Rob said, like a lot of these roles have actually been fulfilled by like EMS coordinators, right? Who may not be a nurse even, you know, or even some of the other crews. So having the NPs do them is really natural, and they can bring added understanding and knowledge to the situation. And they're important parts of our outreach process. And our outreach encompasses not just like marketing, will you call us, but also education, debriefing after events, intellectual and kind of just the emotional stress debriefing stuff. Like they're key members of the team for that. And these are things to think about when you're trying to push a program in an institution that doesn't have one or has one that's minimally involved. Is, you know, you have to think of ways to say, because the reality is they're not going to produce as many RVUs, right, as an NP in another setting. That's just the reality of it, unless you have a very unusual transport volume situation. So, but they can produce value in a lot of other ways. And so the key is helping people understand that and seeing that value, you know, that they can provide educational services and things that would require other assets to do, but they're integrated into the team and automatically going to have a better rapport. And they can do a lot of things that a standard team member can't do, or that even others can't do. Like a CNS outside of transport is not going to do as well educating transport as a transport embedded person will. So,
Yeah, I think, you know, hearing what you're saying about the residencies, and this is another paper in itself, but I think that's the ideal. Everybody on here may not know, but Metro Life Flight, like every month, a new resident, a senior ER resident who's almost in attending will fly. So it's a perfect fit with it when they can fly a day or so with a nurse practitioner who's familiar with giving orders and all that. I always like to tell the residents, you don't have all your support, right? So you have to streamline the top two tasks you want to do, because you can't bark a million orders to one person and expect everything to get done. So it's a great opportunity for the residents. And I found a lot of them, Dr. Bates, don't even know how to tie an endotracheal tube. So, you know, just showing them these simple things or hooking up the vent. And maybe or maybe not, I think having a provider kind of teach them and talk to them and work with them is kind of, it's beneficial for the residency.
yeah. And I mean, honestly, in a lot of EDs in this country, if a doctor, even an attending, touches the ventilator, right, I think an alarm goes off and an RT shows up and throws a tantrum. So, I mean, these are great hands-on experiences for them. It's going to make them be better doctors. This is why we believe in the rotation. And I think, you know, some people said, like, is it harder to have an NP program at a teaching hospital? And I can see in some ways it might make it a little harder to get them autonomous ICU experiences, possibly, but it pays off in other ways because there's a lot of resources poured into education in our division and in our department that the NPs are able to reap the benefits of and feed into. And it is a natural relationship, like Dave said, between the residents, senior residents, and the NPs, and it's very helpful for you guys trying to further this career path, because you're graduating residents, right? EM physicians who believe in this relationship, believe in the value of appropriately trained and appropriately experienced background, you know, nurse practitioners. Because, you know, if you guys have watched any of the social media, like EM physician social media, but I mean, I've been shamed on social media before for advocating for appropriately deployed NPs. Like, there is a lot of backlash right now, and it's not about what you guys do mostly. It's about the fact that there is a glut of questionably experienced and trained PAs and even some NPs out there. So, people that their clinical experience was their BSN rotations for undergrad, right? And so you guys are up against that. That's a reality. It's not your fault, but it's a burden you have to bear. And so these experiences are so positive because our residents graduate with a very positive impression of that experience and those interactions and that professional kind of culture that's there. And that is a force multiplier for you because you send all these learners out that are now faculty or attendings at places, and they're going to preach the same gospel. So, I mean, these are things to think about that can really pay off to help expand your guys' professional opportunities.
What's your vision for ACNPs, your program, and CCT as a whole?
Let's take
We'll
over
say
the world.
APRNs.
So I would say for ACNPs and critical care transport, my vision is similar to yours, Dave, is to get the minimum level of standard of care in critical care transport elevated to the advanced practice model, whether that's ACNPs or physicians or what have you. We often get caught up in the concept that, 99% of the US model is nurse medic. But then if we look at any European model, the Australian model, like these are all physician-led teams. So why are we all dead set on that it needs to be a nurse medic? Is that because it needs to be cheaper? It needs to, be more cost effective or easier to deploy? Like, especially as ACNPs grow in their profession, we're going to have the resource to provide this level of care. My concept too of like, we should be bringing the level and standard of CCT up to that provider level, and also using these practitioners to investigate whether or not what we're doing is actually best practice. Are there things that we should be deploying in the point of injury care or in the interfacility space? Like we've talked briefly about Reboa and ECMO and all these fun fancy things. Like if you start having, especially DNP prepared ACNPs that are qualified to run QI and process improvement studies, we can look and see if these things are going to have a patient morbidity and mortality benefit. A lot of these things have not been investigated in CCT because we're always looking at it from this light of, well, this is a nurse medic crew. We can't expect them to do this. But if we can elevate the minimum standard of what is being provided, we can then look into new and novel ways to treat patients in the pre-hospital environment. So I think we have a ways to go. Now, I'm not necessarily saying that, the NP should start going to Reboa and just see how it all turns out in the wash. But I think there's more avenues to pursue to make sure that CCT is providing what it should be providing, which in my eyes is not a pneumatic tube system where you put the patient in and it quickly goes to the other end. Meaningful intervention, meaningful change by a guided clinician who's there to know that continuity of care, the continuum, anticipated continuum of care, and have meaningful impact and change to it during transport.
So I think you're alluding to it, Robert. But John asked a question in the chat about research that demonstrates or illustrates patient outcomes when you compare crew configurations. He's worked in all configurations and fully supports the advanced practice model. Certainly the strength of implementation lies in part of the outcome data, along with the quality, profitability, and sustainability. But can you, is there anything off the top of your head that talks about research with crew configuration?
This is tough. So what's challenging about this is we have a joke in EMS fellowships is you've seen an EMS system, right? So you have a lot of diversity of how EMS services work, even within the United States, even within the same state, but definitely when you look at other countries. So the outcomes data is hard to do. There is definitely some body, it's a modest body of leadership that does show benefits, but it comes down to there's a massive amount of over triage going on in the United States and air medical transport, without a doubt. And if you're flying people that are going to be flown, it's going to be pretty hard to show benefit of adding someone with expanded scope. But when the studies, they have most of the studies looking at scene traumas, not as much at interfacility. And the scene trauma stuff, like my kind of takeaway, there was one done a while ago where they kind of had like a medic doc or a medic nurse model, like they flipped the medic or the physician essentially in alternating days. And it really came down to, if you had sicker patients, you had better outcomes. It's hard always in EMS research because you have this varyingly but often short window of intervention time. And then the hospital course and the rehab course is often a lot longer. And not only do you have less time to make a difference, but it can be very difficult to know how to attribute different things. You see this in pre-hospital blood transfusion research and stuff like that. It's very tricky to do this. I think it's clear there is benefit because you're expanding those hospital capabilities out. Now, it doesn't mean everything in the hospital is a good idea. So to be clear about that, because there's things that make sense in the hospital that don't make sense in EMS. But I would say that, like, if kind of stepping back and saying it more simplistically, if the system looked like it should in critical care transport in the United States, and what I mean by that is this, what we should have is a lot less helicopters. We should have more robust critical care ground transport. We should have judiciously placed fixed wing resources, especially in lower density environments like out west and stuff. And you had like quality triage coordinating centers and things like that. There's no doubt in my mind that nurse practitioners have a huge role to play in such a system at a number of levels within the coordinating center, on the assets and the education. Now, we aren't there, obviously. That's not what's going on in the US. And there are little islands of people trying to do that, like you've heard in Ohio and in other states. So I think some of it is not just is looking to try to get people to think outside the box and get to what the patients deserve and what the patients need, which is more like what I said. I mean, I acknowledge, I may not be right in every way, but I think most people can agree that where we're at is not optimal. We need to get our way towards that. And nurse practitioners can be major leaders in such a system. So whatever you can do to make a little bit of that system and tap into that idea where you're at, I think the argument for using practitioners is going to write itself. But the devil's in the details.
And I would just add
Specifically,
that I would add that there is data out there for the physician model for a mortality benefit, especially like the European model has published some data on that. So we have kind of used that to generalize some benefit to the NP model. Granted, you can't extrapolate that 100%. Though we have good data also to support like ICU level care and tertiary centers is similar between NPs and physicians. So I think we're making a bit of a jump, but as Craig alluded to, it's very challenging to isolate the benefit of transport. Because if you took two identical patients and treated them exactly the same and you dropped them off to two different tertiary centers, you're going to get two different outcomes a lot of the time. And so how do you attribute the transport clinician's benefit to mortality at 30 days or some of our standard indicators of quality of care when there's so many confounding variables? It's rather challenging.
hopefully that kind of answers your questions, and I think that it alludes to the difficulty of the heterogeneity of patients. And again, do you look at 6-hour mortality? Do you look at 28-day mortality? ICU length of stay, whatever. But
thanks, John. I miss you.
John
Yeah.
Singleton, are you at Lorraine? It looks like Lorraine base behind you.
So for me, real quick, for me, it's less about proving their outcomes are better. For me, it's more about every other part of medicine has figured out how to use NPs within the model. How do we use them now? Because the attrition rate, I don't know, this is one slide or later, but you have a lot of flight nurses who want more. They become APNs, and now where do they go? So I don't know. We'll see.
Sorry to jump in. I have to go to a meeting, unfortunately, but thank you guys so much for having me. It's been a great discussion, and I look forward to hearing about what else you guys talk about after I'm gone. You can say bad things about me now.
Hey, it was good seeing you, Dr. Bates. I appreciate
you
your
too.
input from
Take it easy,
your
guys.
standpoint.
Dr. Craig Bates, thank you, everybody. If you have any questions for Dr. Bates or anybody, please email Dave, dmk104@kstudy.edu.
All right, we
All
got
right.
the doctors out of here now.
You can talk
Now
about
we
that.
can really talk about it.
Um, there's like 7 more slides, Robert. I think we got through a lot of the
Okay.
questions already, but so one of the big questions I get, do transport NPs make more money than RNs? A lot of
Yeah.
places, yes, they're NPs, but they fly as an RN, they're paid as an RN. So how does that work for Metro Life Flight?
So for Metro, and it's the same for Nebraska as well. The NPs are hired credentialed members of the medical staff office. So just like their physician colleagues, they're hired into an acute care nurse practitioner role and scope within the organization, just like any of their ICU colleagues as well. So they are paid based on a scale commensurate with their scope and their kind of their service line. It just depends on the organization how they want to organize that. Most organizations I've seen, it's based on your service line, your level of autonomy, and your years of experience. But as a general rule, yes, NPs do get paid a higher salary and are generally salaried individuals.
So is it fair to say they make equal as working for Metro Life Flight as they would if they were working at somewhere within the hospital as an inpatient?
Um, Generally speaking, the life flight NPs are in a structure where they are on the higher end. So, the urgent care and primary care providers are on a different scale that is slightly lower than the life flight and what they call like ICU 2, so higher level ICU providers.
That seems to be consistent among everybody we've talked with thus far. And we've kind of talked about how CCT programs offset these costs. Do you have anything else you want to add on that?
No, I would just offer that if any programs are implementing or looking to implement, they start the negotiation period with their managed care organizations and their private payers early. It takes a while to change some of those charge masters for how they're billing their trips. Um, there are a multitude of ways you can make revenue changes based on changing to the NP model. No one way is going to be the best for everyone. It's going to depend on your payer mix and your organization and the relationships you have. But you should be changing something. I talked to a program that was investigating the concept, and they didn't understand why they hadn't seen any changes, but they didn't change their fees. They didn't change their base. They didn't try billing provider fees. They're they just really, I don't know if they assumed that it would just happen intrinsically, that people would just pay them more money. But that obviously is not the way that works. So just make sure that you investigate all the appropriate relationships and kind of get that stuff ahead of time. And the reason I say that being, so if you're going to negotiate for charges, say you have a managed care organization and you want to make sure that your base rates are going to get paid appropriately next year, you're going to need to negotiate that in about June, usually for January changes. So if you stand up your model next year, you're not going to be able to negotiate until the following June and not see changes until the following year. So if you want to make sure that you're going to get the appropriate services paid for, negotiator.
Yeah, Robert, one of my views changed, well, not changed, but one of the things people ask me, I think the nurse practitioners that work in transport have to understand they need to do something to cover the money they want to make, me included, right? So when I went from an RN to making more money, I think I wanted just to be a master clinician or think I was a master clinician and collect a larger paycheck, but it's got to work for the organization as a whole. So you need to figure, like, you have to understand, I think, that you have to provide the value even more than just being a master clinician. Otherwise, the
Yeah,
finances may not work.
100%. And especially as you grow into an organization with the NP model, part of my job is to talk to my administrators and upper level management and continually re-demonstrate that value. Um, especially with critical care transport, administrators that have been around a while love to lean on this concept of downtime and how this is lost productivity and you should be doing stuff during your downtime, yada, yada, yada. So one of the things I have to do is make sure I clearly tell our story of this is the value that my group is adding. The NPs are doing 700 chart reviews every 6 months. They're spending countless hours on this. They have completed 350 hours of resident training and education for the emergency medicine residency program. They've done X number of lectures for EMS providers. They've lectured nationally. They published. These are all the things that matter to hospital leadership. And one of the things we just need to do is make sure that we tell that story appropriately so they know where their money's going and that it's
Right.
well worth it.
And the NPs in the industry, they need to be creative and like figure out ways, because downtime of not bringing in any income isn't gonna work long term, right?
Right.
All right. Are there differences in the scope of practice between CCTNPs and RNs?
Yes. Yeah. So scope of practice is a kind of a vague concept in most CCT programs because most operate under fairly lenient protocols to allow RNs and medics to typically exceed their standard scope of practice. Transport has gotten away with some stuff for a lot of years. And I think honestly, that's going to end up being one of the big pushes for the APRN model, is kind of right setting with the legality of scope of practice. So I can tell you as an example from Ohio, there was another program in this state that asked the state board if it was okay for their nurses to place chest tubes. And the state board answered with a resounding no, nurses cannot place surgical chest tubes. Um, doesn't mean it hasn't been happening for 30 plus years at this point. It's just a thing that kind of went and kind of floated through without anybody noticing. So that program stopped doing chest tubes. Is that the best thing for patients, or do they need to bring on a clinician that can perform that procedure? So I think those kinds of discussions and investigations into kind of right sizing scope of practice is going to happen. A different conversation is the utility and benefit of some of those procedures. And you'll get different answers based on the different programs and whether or not their patient population supports that. So an example being in our program, the nurses and medics cannot place arterial lines. They could at one point in time, they cannot now. The NPs can. That's well within their scope of practice to place an arterial catheter. But do the patients that you transport need art lines? If you ask a Metro Life Flight person from Cleveland and you ask a Cleveland Clinic person from Cleveland, they'll probably give you two different answers whether or not that's a necessary procedure based on their patient population. So matching scope of practice to the level of care, I think, is important. Matching the actual practice with the patient population is also important. But yes, as a general question, scope of practice does differ between NPs and medics, though our NPs do oversee the nurses in particular, perform a number of procedures. Just because the NP's on the trip doesn't mean they're going to do all the procedures. We like to say that we practice more of an attending physician role where we're happy to guide and mentor, and sometimes the RNs are more experienced than the NPs based on longevity and seniority, and can contribute a fair number of learning details to the NPs and procedural competencies. So I don't want to say that it's a huge difference in scope of practice, but for legal purposes, generally speaking, the NP is going to be overseeing the procedure.
What are the obstacles that hinder or limit the potential of the NP? This could include factors within your program, CCT as a whole, or even government operations.
I mean, the biggest obstacles I've seen that hinder like the implementation of nurse practitioners in critical care transport is A, financial, and B, stemming from just kind of misunderstanding of what the benefit is. again, it's one of those things of telling the story and the whole story while doing so in an elevator pitch most of the time. So most executives that have denied people's requests to start this model tend to just purely focus on the salary difference, and how, we're barely scraping by right now. We can't afford more salaries. But they tend to not either accept the information or not be given the information of all the other value adds that the NP model has. So it's hard to get into the door, right? And then just misinformation on what exactly the NP scope is, and the benefit to patients and to the organizations, and PR and outreach, and the vast multitude that the NP model can bring, is really the biggest obstacle that I've seen. If you get a good stakeholder that understands the benefit of nurse practitioners, like Craig mentioned, a good CNO, and the CNO at Children's in Nebraska is very much behind the NP model. She's all for it. It makes all the difference in the world. And then once you're in the door, it's easy to show benefit, because everybody's looking to see what you did. But it's kind of getting that first hand to, reach out and help you up kind of deal. For operations and other challenges, state to state variance in practice is going to be a challenge. Certain states, scope of practice is tough. Credentialing is tough. It just depends on how liberal your state is on scope of practice, and how much your facility that you're privileged at is willing to allow you to do autonomously, because they're probably not used to that. A lot of places, I'm going to say like California, has a pretty low scope of practice. Like one of your credentialed procedures has to be chest tube removal. Well, in Ohio, that's a nurse skill. You don't need to be credentialed in chest tube removal as an APRN, but they do there. And they may say you may not do certain procedures without a physician on the unit. Those types of organizations are going to struggle with autonomous practice. And I just want to throw one random thing out there, because we never really touched on it. And I get this question a lot, is what about PAs in critical care transport? We have never done PAs at Metro Lifelight. And that is because of the Ohio statement of PA practice, is that a physician has to provide oversight of their practice. And at one point, I believe the definition was as strict as the physician had to be on premises, versus the NP collaborative practices. I just have to be able to get a hold of a physician at some point in time to discuss care if I have a problem. So obviously, since we don't work in a facility, we don't have a physician for that PA to, turn to on site for care. So those types of things are going to be a challenge state to state as they differ. Doesn't mean PAs can't practice in critical care transport. They probably could in certain states. It just depends on how that goes. And if they do, I would definitely recommend a PA with a critical care fellowship, because they are generalists in training. It would be very similar to the FNP model with just a more diverse scope of clinical orientation. So either a PA with a strong critical care background or a critical care fellowship. But yeah, those are the obstacles I got.
I think just two more slides, Robert. How do you keep up to date with the latest advancements and protocols in critical care transport? And then what strategies do you use to maintain your composure and effectiveness in high stress, fast paced environments like CCT? So not so much a NP question, but in general.
Yeah. So keeping up to date stuff it's tough. A lot of lecture or journal review. I have some, standard updates or notifications that, email me on certain topic changes, lectures, protocols. I review people's protocols a lot, just to see if anybody else is changing practice and if we should be too. Attending conferences. I usually lecture at AMTC or CCTMC. So I'll, attend lecture there, listen to conference stuff. Podcasts are super helpful. I got about a 45-minute drive each way to any of our bases. So, especially in the morning, I like to listen to medical podcasts, critical care transport podcasts. So it's helpful to kind of keep up. But man, like I said, if you don't have that kind of built-in place for reps, I mean, it's a heavy burden to maintain that updated practice on your own. For composure and effectiveness stuff, and that really comes down to the person. I guess the best way I would say is just detachment. I don't know how else to better describe that. But essentially kind of compartmentalization of I'm just here to do this task kind of mentality. And usually that works fairly well for me. Um, if you're getting real hyped up and your tachycardia and tachypnea is getting the best of you, some box breathing, visualization, that kind of stuff can usually help. But I feel like kind of just reps overall is gonna kind of better acclimate you to the space. Um, and I would just say if you have troubles, don't be afraid to reach out because everybody's started somewhere. Everybody has that call that triggers them. Um, Seek help if you need help. I can tell you, kids didn't bother me until I had kids. And then I had a couple of cases that were same age, bad situations, and sometimes you got to talk to people. So
Yeah,
definitely find those colleagues, reach out if you need it.
100%. Well, that's it, Robert. This is kind of an open question. I think we got any chat questions already that came through.
Yeah, chat's been answered. If anybody has any questions for Robert or in general, please put them in the chat now.
You have anything else you want to add?
No, I don't think so. It was good talk. And I've been staring at John Singleton on my screen because he's got his camera on this whole time. John was my big mentor into CCT here at Lifelight, so I'll give him a big shout out for the person I am today is built on John's shoulders.
Yeah, same. I came as an NP to Metro, and John's a flight nurse, senior flight nurse. Uh, and he taught me a lot as well. Good to see you, John.